Hello, everybody. We're going to give everyone just a moment to get connected before we get started. Excellent. Got some people popping in at the top of the hour. So just get settled and we will get started in just a moment. Excellent. Welcome. Okay, looks like I've got a few people that can hear me, which is great. All right. Well, while you get settled, I want to go ahead and jump into everything. We've got some more people that are going to be popping in and joining us. But welcome to our very first session of the 2023 Maternal Health Learning Series. I'm Jen Anderson, the Clinical Quality Improvement Director for CHAMPS, your Region 8 Primary Care Association. Community Health Association of Mountain Plain States, or CHAMP, supports the needs of health centers in Colorado, Montana, North Dakota, South Dakota, Utah, and Wyoming. So while we are all getting settled, I want to encourage you all to put your video on and to rename yourself so that we can get a good idea of who is in the room with us today. It's really important to our HRSA funders that we know who's joined us for this event. So if we have a name that's recognizable, that will help us do that, which is fantastic. Speaking of HRSA, this series in particular was created in partnership with the Region 8 Office of Intergovernmental and External Affairs. As you all know, that maternal health is a really important federal priority area. So we're super thankful to Captain Alicia Aker for helping us bring this series to you all. So while we're getting settled, I'm sure you guys are all Zoom experts at this point, but you can rename yourself by hovering over that little ellipses in the top right-hand corner of your picture. If you're having trouble with that or have any technical difficulties today, please reach out to Haley. She's at Chance Tech Help in the chat, and she can get you all settled and fix all of those issues that you guys are having. So today we're going to be talking about reducing stigma in pregnant people with substance use disorders. Our speaker today, Dr. Meredith Sjogren, is a clinical professor at the University of North Dakota and a certified nurse midwife. She is with the Mountain Plains Addiction Technology Transfer Center, a SAMHSA-funded training and technical assistance organization that provides training and resources throughout Region 8. So they're a fantastic resource for you all. A full bio and the slides for today's presentation can be found at the link in the chat and also on the CHAMPS archive webpage at champsonline.org. And of course, because I know you're going to ask, the recording will be added to that page a little bit later next week, most likely. So I see you all need a little encouragement to turn on your videos. I'm happy to do that. We want to talk a little bit about sharing and being part of a discussion. I don't want anyone to click away just yet. You are not going to be required. Oh, good. Samaritans that are popping on. I love it. You're not going to be required to take part in any discussion at any point if you do not want to. So don't feel the need to pop off the event. Meredith has a really fantastic presentation, and you're welcome to stay quiet and simply just soak in her wisdom. With that said, I've got two reasons that I would really love for you to join in our conversation. First off, you're going to learn so much more from Meredith and from each other if you will all join in on the discussion. Meredith has a fantastic professorial quality to her presentation style, and we can just allow ourselves to be whisked back to college for just an hour today on this fantastic fall day, if you guys will be willing to share. If you have something to add in our discussion portion of the presentation, you can raise your emoji hand or your real life hand, and we'll invite you to come off of mute and share your perspectives. If you have questions throughout the presentation, you're also welcome to notify us or to leave a question in the chat box. If you would like to message me privately because you don't want everyone to see your question, that's also perfectly fine. You're welcome to do that as well. And then when we get to our Q&A portion, I'm happy to raise that question. Feel free to add questions as you think about them, and we'll potentially get to them as we go through. Next, there are a number of TDTA providers in the room with us today. So CHAMPS is here, some of your state PCAs are here. Meredith, as I said, is from a TDTA organization, and Alicia from HRSA. And we all want to know how best to support you and to learn about your pain points and what you need from us to help you all. From the PCA side, we're writing our competitive cooperative agreement right now. And so it's a super unique time that really only comes along every few years, where we're really able to kind of pivot our training to focus more on what you guys need. So with that in mind, I would love for us to open up and share a brief icebreaker activity for those who feel comfortable doing so. I would love to go through and introduce yourself, tell us your name, your job, your health center, and then just share with us why you wanted to hear about this topic today. Or if this one just kind of sounded interesting for you and really you're focused on something else, please tell us one thing that you're concerned about or you're focused on addressing at your health center, either as it pertains to perinatal SUD or to maternal health more broadly. Anything you like. I will not call on you unless you raise your hand to indicate that you'd like me to do so, because I want to respect the needs of those who don't want to participate. But I would really encourage it, and I would love it if some folks would come off a mute and agree to introduce yourself. Let's get to know each other.
I'm Deborah Harris, and I just moved to Montana from Austin, Texas, to take a position here as a position that I had previously, which was peer behavioral recovery support specialist. And then I'm adding doula training to that. So yeah, I know. I'm super excited. That's why I came up here. And and I work with One Health.
Glad Jen, my work is done. We can go home. We've got a doula in the crowd. I love it.
Excellent. Welcome. I'm a Texan myself, so we welcome you out here. Awesome. Who's next?
I can go next. I'm Heather Tintermasakia with Community Healthcare Association of the Dakotas, also known as CHAT. I'm an improvement coach, and I've just always been really passionate about maternal health. So when this invitation popped up, I was very excited to register. So thank you.
Excellent. And Heather wants to hear about all your pain points too, so that Chad can help to work on them. So excellent. Who's next?
I'll go. I'm Eve Williams. I am a licensed addiction counselor and a licensed clinical social worker in Durango, Colorado, and work with community mental health, Access Health System. And we've been seeing a huge increase of pregnant females coming in. And I actually, right before this invite came, I just started a parenting and substance use therapy group. And so when I saw this come up, and I was like, well, that's a sign that I need to join in on these. And so I'm kind of diving more down that road in my practice.
Good. That's great. Thank you. Any other takers?
I'll go next.
Yeah, please.
So my name is Stephanie Carrillo. I am a MSW student and I'm interning at Inner City Health. And my supervisor sent these trainings to me to see if I was interested. And yeah, I wanted to learn more about this topic since I haven't. So yeah, thank you.
Great, thank you.
I love it. Eve, we have the college where I'm dean. We are 3 different departments: nursing, nutrition and dietetics, and social work. And I have had the pleasure over the last couple of years learning so much from my social work colleagues from the academic standpoint, but from being a nurse midwife in practice for a number of years, social workers were on my speed dial. So I'm incredibly grateful for the work that you all do in this scope of care. So thank you.
Hey, I'm happy to go next. My name is Laura Penny. I'm a family doc in Denver. I'm with Denver Health, and I am director of family medicine. We have a huge network of FQHCs, have done and do lots and lots of prenatal care. We've done a really good job, I think, at decentralizing addiction treatment among the not pregnant. And I think we haven't done as good a job at getting women treated in their own communities. And so that feels like the next step. And so I'm listening in really to learn more and to try to develop a little bit of a vision of what that would look like.
Well, thank you.
can go. Hi, I'm Tracy Bird. I am the maternal health manager for Horizon Healthcare, which is an FQHC system in South Dakota. And I recently came on within the last couple of months under a HRSA grant, which is looking to develop a maternal health department and education program, teen pregnancy prevention, some remote patient monitoring, lots of different components there. One of them being the integration of behavioral health. And I've been in several conversations around this topic and like plans of safe care and some of those things, and just want to learn more and see how we can best serve our patients.
Excellent. That's fantastic. And we're interested in learning more about what Horizon is going to be doing with that maternal health grant. So more to come. Excellent.
I'll go next because I also work for Horizon Healthcare with Tracy, and I am also new to Horizon Healthcare. I'm a Jeannie Keating. I'm a nurse manager here in South Dakota, and my history though is I was a labor and delivery nurse for 33 years before I took this position. So of course, anything maternal health is my passion, what I'm interested in. So thank you.
Welcome.
And I guess I'll go next because I work with Horizon with both Jeannie and Tracy. I'm a physician assistant and I work up in Fort Thompson on the Crow Creek Reservation. Very small clinic. I don't see much of maternal care, but I see an awful lot of sexually active, very, very young adults. And I also do our family planning clinic. So I figured I would rather attend today and have some knowledge behind me before hopefully I start seeing some maternal patients.
Excellent.
Diane, I worked in family planning for years, still one of my absolute favorite places to be. Again, respect the work that you're doing very much.
Excellent. So I think we've heard from, I'll let Haley say hi. Hey.
Hi, I'm Haley Donahue. I started with CHAMPS in September as the programs coordinator for membership and communications, and I'm here for tech assistance today. I'm really excited to learn more about this topic.
Excellent. So we've heard from everybody whose video is on. I'll give just a moment of not talking to see if anybody who is just calling in would like to introduce themselves. Okay. Perfect. Well, thank you all so much. I really appreciate you guys taking the time to do that. And with that, I would love to turn it over to Meredy. Would you like to start sharing your screen?
Yes, I sure will. We'll give it a whirl. You'll tell me if it's not working.
Sure will. You're up, but not in presentation mode just yet.
Go.
And now that looks great. Thanks so much.
Okay. All right. Okay, I will go ahead and get started. If you have questions, please pop them in the chat box. I think Jen and Haley will be kind of monitoring those, see if there's anything we need to address in real time. Otherwise, we'll try to leave some time for questions at the end. As I get going here, a couple of things I just need to share with you as being part of a grant team. I've actually had the privilege of serving on the Mountain Plains Addiction Technology Transfer Center grant team since we started in 2017. Prior to that, I was able to work in the same scope since about 2014 when we had our first SBIRT grant come into the University of North Dakota and been able to kind of fold things through. So right now we primarily provide training to folks in Region 8. Some of the content that I'm sharing today has also come from a grant that I was the PI on called Don't Quit the Quit that has allowed us to also bring this information nationwide. So you'll see kind of a mix of different perspectives brought into that. As of course, SAMHSA asks, the disclaimer is the information that I'm sharing to you today has come from my experience, my research moving forward, and it is not necessarily the same sentiment of SAMHSA, but you have that disclaimer there for that. So today I'm hoping that we'll be able to talk a little bit about the differences that people who are in that perinatal scope of time are experiencing when it comes to stigma. We're going to talk about that specific impact of substance use disorders and hopefully brainstorm a little bit together about different ways we can reduce the stigma in healthcare today. As always, we like to remind everybody that our language matters. Our words have power, and we should always try to put people first. If I misstep today, call me out. That's how we learn and how we keep getting better at what we're doing, but we'll make every effort to put people first in the language as we discussed today. Okay, so just to kind of put us all in the same perspective of what I mean when we're talking about substance use disorders, we are going to be talking with the idea that a substance use disorder is a chronic medical disease. It is characterized by continued use despite harmful consequences. And one example of this would be an opioid use disorder, where that pattern of opioid use is characterized by tolerance, craving, the inability to control their use, and continued use despite those consequences. Addiction is definitely the most severe form of the spectrum of substance use disorders, and it does fall into that scope of being a medical illness. So try to be open to that definition as we're moving through today. Stigma is a significant barrier to caring for people with substance use disorders, but the reason we offer these kinds of webinars and education is because education provides us with a significant opportunity to improve the care that we're able to provide to people with substance use disorders. Second definition of the day is stigma. So we have the book type of definition and another one that I want to share with you. So by the book, stigma is sometimes called explicit bias. It means that we're talking about attitudes, beliefs, feelings about people or groups that can motivate us to consciously discriminate or marginalize within those populations. But years ago, I came across this definition of stigma: an attribute that is deeply discrediting and reduces the bearer from a whole and usual person to a tainted or discounted one. And this definition spoke to me because of the work that I have done caring for people who are pregnant, especially. And even in the absence of substance use disorder, it seems that the perinatal period decreases self-confidence for so many people. We have presumed stereotypes that are attached to that, different ways of practicing. And I see women in particular being feeling like they're less than or they're not whole. And so this really spoke to me, and I always try to include this as that perspective of thinking about that whole person, not just the substance use disorder that they're experiencing, but that whole person and what they're going through during this perinatal period. Substance use disorders are some of the most stigmatized conditions in the world, and we know that people who are pregnant or parenting with a substance use disorder are particularly impacted. When we talk about the burden of stigma, what I'm referring to here is how we look at different disease processes in the light of stigma. So when we have a diagnosis of a disease or we have a diagnosis of a substance use disorder, people may perceive the implication that a person will have control over that condition and they are actually at fault for acquiring it. And we have those that will never be stigmatized, and then we have those that are. And one of the examples that I like to use is if somebody is diagnosed with, say, breast cancer, I cannot think of an instance where somebody says, you deserve that, you were at fault, that is your fault for having that disease. But if that same person develops a substance use disorder, we immediately perceive them to be at fault. They should be able to stop using that substances. Why did you do this to yourself? And we place that blame for it to be there, but rarely on an instance for cancer, for example. So right there, we have a whole different burden that sets the tone for the type of stigma that somebody might experience. The consequences of stigma run far and wide, anything from changing their self-worth, their self-image, to leading to depression, anxiety, becoming defensive. In this scope of time that we're talking about, it can lead to suboptimal prenatal care. If we don't provide care that's grounded in empathy and respect, we actually can cause re-traumatization. We can trigger a return to use, and we can further impede their access to care. We also know that because of stigma, many people will not engage in treatment or they'll leave early, and it can even help contribute to death. There are many different views of stigma, and I'm just going to point out a couple of them here. And really, these are just meant to broaden our understanding of stigma so that there isn't just one view of stigma, but I want us to try to think about all the different layers of stigma when we're working with the perinatal population. So we certainly can have perceived stigma, or that internal belief that others have a commonly held stereotype or about a stigmatized group. But then we have public stigma. And this is where our community actually endorses those stereotypes, and we see discrimination happen. This might be within your healthcare system. It can be within an organization or a clinic, a federally qualified healthcare center. But we know this broader public stigma especially can undermine the type of care delivery that we are trying to provide. Self-stigma, I think, is really interesting. So this is that internalized belief that someone will start to have about themselves. And I ran across some information by Recto and her colleagues, and it was just fascinating to learn about the 4 different stages of self-stigma. So what often will happen within a person is that they will become aware of that stigmatization, and they will say to themselves, society thinks that people who use drugs are bad. Then they'll start to agree with that public type of stereotype, and they'll say, you know what, they're right. I believe that they're right. Then it turns inward, and we see the self-application of stigma, and it says, oh my gosh, I have this condition. I have an opioid use disorder. Therefore, I am also a bad person, and now I'm a bad mother. And that leads to a decrease in self-esteem and self-efficacy. And why should I even try? Society thinks I'm bad. I think I'm bad. Why should I even try to make a change? This overall impact of the self-stigma can directly sabotage any type of treatment option, the outcome of that treatment, just because of that sustainability of those negative emotions. The lack of quality healthcare due to self-stigma and shame will impact both mom and baby. So from here on out, when we're talking about this dyad, remember, we've got 2 people in this situation. A little bit of some difference when we start talking about implicit bias. Now, implicit bias refers to the attitudes or stereotypes that adversely impact or influence our understanding, our actions, and our decisions in an unconscious way. So these don't necessarily reflect our core values and a belief, and it might be different than what we say isn't actually what we're believing. But think about what we hold internally here. Now, healthcare professionals with strong implicit biases might actually be providing a lower level of care. It might lead us to show less compassion. We might not provide full information, or we might offer misleading information. We might spend less time or effort in a therapeutic type of a relationship with our clients, and it can even lead us to disregard the values and perspectives of certain clients. So if you had someone, for example, who presented 20 weeks pregnant, they have a significant alcohol use disorder. Sometimes internally, we might have some anger. We might display that as like, well, why are you even here for care? We won't use that person first language. We might not provide them with all of the potential complications that we could see because of that alcohol use in pregnancy, because we think that they don't want to know, or it wouldn't mean anything to them. It wouldn't make a difference in their use. And it may help or lend itself to us checking off the boxes, getting through a visit, but not actually spending that quality time and focus on the education that we should be including in those visits. Are healthcare providers vulnerable to bias as well? And that is quite possibly true. If we think about the healthcare structures in which we work, bias sometimes informs the type of care that we provide. And so our healthcare decisions are often based on data. For example, well, if we're collecting data and we don't have solid representation in that data from minority populations, underserved populations, we're creating plans of care based on the most likely responses to that data, or the people that contributed to that data. And if we have people who are underserved not coming in to see us, they're probably not part of that evidence that we're collecting. So because of that, we have these standardized systems of care. I don't know about you, but I like a good algorithm. I like to say, here's the problem. What do I do next? And follow through that pathway. But I seldom stop to think about, is this standard of care the right choice for every client that I'm seeing? This might lead us, our bias, our lack of evidence-based data, our lack of representative data might lead us to not having the best individualized care options simply because of the structure from which we work. What about our internal narratives? I would argue that every one of us grabs that chart. We're ready to go into that client's room and we take a quick peek at what's in that chart. We look at that demographic data. And would you agree that maybe we start forming internal narratives about who I am about to see before I actually go in and start visiting with that client? That might come from a place of bias before we start engaging in that appointment. We have a lack of diversity across our medical professions, a lack of racial, ethnic, cultural parity between our providers and our patients. That changes that dynamic. And we have an overall lack of training available on bias and stigma, health disparities, cultural awareness in all of our professions. So are we talking about stigma or implicit bias, or both when we look at culture? In our culture today, women are typically socially assigned the roles once they become pregnant as mother, as caregiver, as wife, and they're seen as being quite central to that family unit. But when that pregnant person uses drugs or develops a substance use disorder, this violates that construct of how that person is supposed to be in that role, and it leads to more stigma. Mothers with substance use disorders have historically been considered to be very selfish. We've even said they have a moral failure. Many people in society will believe that they're causing intentional harm to their family, and they are personally placing a burden on society. This continues to drive that self-stigma that they have, or that perceived stigma that's out in the community. And it really lends itself to weighing in on that struggle between secrecy and disclosure. So if this is the perception that's out there, this is what our culture thinks of this person who is pregnant with a substance use disorder, why should they disclose? And they'll often hold it to themselves because they don't want to bring more stigma upon them. We certainly do see stigma disproportionately noted among poor people and people of color. Now, if we really look at this impact of motherhood on stigma, I would like you to think about the entire perinatal period here, from preconception to postpartum, and I probably should have added intraconception as we're planning for that next pregnancy. So what is the dialogue that we're sharing with people who are in that space? When they're in the preconception period and they have a substance use disorder, we tell them you shouldn't have a baby. Once they become pregnant, we tell them you're hurting your baby. Once they're postpartum and have had that baby, we tell them you can't care for your baby. And if we would add interconception, why are you even thinking about another pregnancy? Because look at what went wrong in the first one. So we really have set up this entire dialogue to follow them through this entire perinatal period. We know that this type of stigma occurs from many different people. It comes from our healthcare providers, the general public, their own loved ones and families. It comes that internal from themselves. And interestingly, when they've studied stigma in the addiction community, and here I'm talking broadly about, say, support groups. If somebody were to attend an AA meeting, for example, or they had that support network that they went to, that many people who are part of that community have felt very, very supported until they disclose their pregnancy to their support community. And then they describe feeling a whole different shift in that support and feeling more stigmatized because now they were the pregnant person with a substance use disorder, as opposed to the person with the substance use disorder who was engaged in that community. I found that fascinating and sad, that some place where we would perceive the support to come from is actually changed upon disclosure of that pregnancy. We know that disclosure of a substance use during pregnancy can lead to financial, emotional, legal consequences, and many mothers are reluctant to seek treatment because of the fear of legal action or social service involvement. We also know that as many as 70% of women who enter into treatment for a substance use disorder have children, and they hold primary responsibility for those children. So if their family responsibilities are interfering with their ability to attend treatment regularly, it decreases the likelihood that they will be successful in that treatment program. So our first stop point, to give you an opportunity to weigh in if you would like, and think about some of these kinds of things. So I would like you to just first think to yourself about these following statements. How would you feel? What would your response be to seeing a mother in a pharmacy filling a prescription for a prenatal vitamin, and you overhear them also filling their prescription for buprenorphine? How would you feel if a mother came to you, she had an active SUD, and she asked you to help her plan for breastfeeding once her baby was born? How do you feel if you're in a prenatal appointment and you're discussing alcohol, or a preconception appointment and you're discussing alcohol use with a mother who is trying to conceive? And if you're visiting with a mother who tells you they've stopped their contraception because they would like to have a baby and they have an active substance use disorder, or they're in treatment for a substance use disorder, what is your first impression? Is there anybody who's open to sharing their thoughts here? Debbie, I see a hand.
Yeah, I'd like to think that how I would feel and how I want to feel, but when you were going through some of your discussion, I was like, wow. I think I think that,
Yeah.
like when you said society and believes this, and then I start to believe it, and society
Mhm.
thinks I'm bad, and then I think I'm bad, and yeah, I think I have some discrimination and definitely some issues on the subject, and it's very eye-opening, and I'm like kind of a little disappointed in myself because I thought I was above that. Do you know what I mean? And I'm not above it. So this gives me a chance. This really opens my eyes to see what's really going on in my brain. So now I can work on changing it. So
Yes.
thank you so much.
So completely honest, Debbie. Thank you for that. And I think many of us probably have that same type of a feeling. When you see it in print and say it out loud, it has a different meaning than if we're just thinking through things. And I agree with you. It's some of that internal or that implicit bias that we may not even be aware of. Anybody else wanting to share a thought here? In a safe
My
place?
initial, oh, sorry.
Yes, go ahead.
My initial reaction was on each of these bullet points, it seems like we're talking about, two, contradictory things. And I'm happy that the patient is able to openly talk with their provider about two stigmatizing things that are occurring in their life. So my initial reaction is that if you're to the point where the patient is able to share both of these things with you, you're already like steps down the road compared to where a lot of people are at, not being able to share, part of their struggle because of the stigma that does exist. So that was my initial reaction.
That is a great point, and I've not had anybody bring up that perspective before. So thank you for that we have to look at the positive of this scenario as well, for what that means. And to make that progress where they do feel comfortable to disclose, that is huge. Thank you for pointing that out. Any last thoughts before we move on?
For me, I noticed different internal reactions for different ones on here. So like the first example, I was like, oh, well, that's great. That's harm reduction, is going in that direction. The second one, that I had that probably the biggest internal reaction as far as like, okay, that in my mind felt like a choice then, like you have the choice to do the formula versus the breastfeeding. And if you're in that, and so then my mind's like, okay, maybe they need to be educated around, the impact of what can come through in the breast milk and the alternative options. And that's where the next ones kind of came. Not like, yeah, the second one was the biggest one that I had. And discussing alcohol use with the mother, that to my mind goes also to the education part. Is alcohol is so normalized in the society too, and a lot of people don't really recognize the harms that can come with that, and so lots of opportunities for education.
Yes, agree with you. The education, and we make a lot of assumptions around education. Sometimes after we worked in this field for a while too, we forget that people aren't aware of potential complications or the impact of different substances. Or when it comes to breastfeeding, if we have somebody with a substance use disorder who's in treatment and say that they're using buprenorphine, that they could safely breastfeed. And the assumption becomes that they can't because we assume. So multiple ways of education can change the perspective that's here. So I thank you for talking about the differences that you noticed with those scenarios. Okay, excellent. Okay, so now I want to move on and talk specifically about healthcare culture. So we kind of talked about societal culture and how women in particular were viewed, but I'd like us to think about our healthcare systems and even where you're working right now. So each healthcare interaction occurs in the context of at least 3 different cultures. And one is the healthcare provider's lived experiences. So all of us who come to this work have had different experiences being that healthcare provider. We also have the experience or the culture of the person who is seeking care. We don't necessarily know how that person has been treated before, if they've had positive experiences in healthcare or if they've only had negative experiences in healthcare. And then we have the culture of the healthcare system itself. So sometimes we'll work in, this clinic setting, and there's a whole different culture of the people we work with than it is in the one that we worked with 2 years ago or in the future where we'll work. And that can be called institutional stigma, or how that healthcare system portrays care for people with substance use disorders. I, Merity's version only, would like to offer the thought that we consider a fourth context or a fourth culture, and that is of our broader community, the state in which we live, the city in which we live. If you're used to working in rural areas, sometimes we'll see significant differences in culture between rural communities and urban communities, even state to state. And I think especially we're thinking political views, we're looking at generational knowledge that's passed on, I think we have to consider our broader community into this scope as well. So we know that there's a wide variation of attitudes, beliefs, and behaviors amongst all people, but all of these variations will include some type of stigma and some type of bias. So please consider that a single interaction with a healthcare professional can be empowering, or it can be one that will negatively impact all subsequent interactions. Next discussion point. Would any of you be open to sharing a not so pleasant healthcare encounter that you have had, either as a provider delivering that care or as a consumer? And when you're thinking about that healthcare instance, is it something that impacted your future care options? Did you recognize any stigmatizing behaviors that occurred at the time of that encounter that you maybe didn't consider until months down the road? And have you thought about that negative healthcare encounter since it happened? Now, this one has a lot to it, and I'll start you out with my own personal example. And it would be the time that I had my very first kidney stone and didn't know what it was, and had to present to an ER where it was immediately assumed that I was drug seeking. And I was having the most excruciating pain in my life. And they would not give me pain medication until it took a long time to get the x-ray that said, oh, look at that healthy stone that's right there. And I have gone back and thought about that so many times. Did I present in the wrong way? Did I say that my pain was more than they believed that it was? Did I not answer the pain scale correctly? What was it that led to that encounter? And I really thought about how I was treated many times since that happened. And in fact, that happened in 2012. So 11 years later, it still has an impact on me. Have any of you had a similar experience as a patient or as that provider? Debbie?
I also, as a patient and a substance use disorder, had a doctor in the ER. I had this big, huge infection on my arm, and from needle, using my own dirty neat points. I mean, I'm just going to tell it like it is. That's how I am. But
yeah.
And he just started doing surgery on my arm with not even can't think of that pain medication that he could have shot in that to make it a little less painful. He didn't use anything. He just started doing surgery right there, opening up this huge wound. I started screaming in pain because, at the touch, it was horrible pain. It was a huge abscess, and everyone looked at him in the ER like, because I was screaming, that's not the right thing to do and stuff. And he finally, against his will, gave me something for pain, and then finished the surgery. But that has affected me and will continue to affect me for a long time also.
Absolutely. Thank you for sharing. Thank you, Debbie. Anybody else think of an encounter that they've had, or as a provider that you've looked back on an appointment and you thought, gosh, I could have done something differently. I could have maybe been a little bit better in this particular area. Anything? This is a hard one, and you don't have to share, but think about it at least. Okay, maybe we're going to internalize that one. Okay, so keep thinking about it just a little bit as we go next. Okay. So in that context of thinking about negative healthcare encounters, I'd like us to really think about negative perinatal healthcare encounters. And we know that mothers with substance use disorders have described through many different research studies the kinds of negative encounters they have had during this perinatal period of time. The article that really set the basis of this section of the webinar came from Renberger and Associates, and they had looked at 23 different qualitative studies that were conducted with people in the perinatal period. So either they were pregnant, they were postpartum, they had a baby in a NICU setting, they were in for clinic routine care, or even some family planning visits. And they wanted them to describe the kinds of experiences they had had while being a perinatal person with a substance use disorder. And they came out with 5 different themes that they found with all of the people who participated. The first was described as a judgmental encounter, meaning that they felt that the provider very much disapproved of their substance use disorder. They felt they were being looked down upon. They sensed a lot of blame if their infant was experiencing withdrawal symptoms, and this led them to feel shame, frustration, irritation, and just being dismissed as part of that visit. The second theme was called scrutinizing healthcare encounters, and that meant that they said they felt that they were really being watched very, very closely. They were identified by multiple people as being the drug user, not the person who had a substance use disorder, and it caused many mothers to just avoid prenatal care in general, or they lied about their substance use disorder. Some women even admitted to using other urine for their drug testing because they just didn't want to be monitored that way. They felt that they were always being observed to see if they were high when they were holding their infants, or if they were visiting the NICU, or even while they were breastfeeding. And it really led to them questioning their ability to mother. And that led to an inhibition of the mother-infant bonding. The third theme that came out was that they called a disparaging visit, meaning that these visits included overt critical behaviors. So they saw people rolling their eyes, they experienced name calling, they heard people whispering about them. In particular, one person reported hearing the whispering outside the exam room door before the provider came in. And this really contributed to a low sense of self-worth. They also described visits that were disempowering. They felt that they had little or no control over their own health or making decisions about their infant's health. They felt that people didn't believe them, they didn't listen to them, and if they brought forth a different kind of healthcare concern, nobody took it seriously. This led them to having no voice in their decisions, and they even didn't get to help talk about what kind of treatment options they would be interested in. And this led many mothers to feeling frustrated and angry. And the final type of visit that they described was one called deficient care. So that mothers with substance use disorders stated that they often felt they received a lower quality of care because of their substance use. They didn't feel that they were given adequate health information. They didn't feel they were given time during their visits because of their substance use, and it caused most mothers to stop coming in for prenatal care. Research actually tells us that mothers desire more information about their substance use disorders during pregnancy. They want to know if there are treatment options. They want to know if they're going to be able to breastfeed, and they want to know what type of healthcare is going to be best for them during that time. So I'd like you to take all of that and think about it this way. When a person engages in routine care during the perinatal period, just routine, not talking about even extra appointments for complications or specialty appointments, just routine prenatal care, they may have 9 prenatal visits. They might stay in a hospital setting for 2 days with their labor and their postpartum stay. And if we're lucky, they might come back for 1 postpartum visit, which, by the way, only about 40% of people ever return for a postpartum visit. Okay. So if we look at that and we see here that then we have about 12 different visits that we're talking about. And if you remember that each of those interactions or those healthcare encounters occurs in the context of at least 3 cultures, that means that if a person discloses their substance use during that pregnancy, they could potentially have at least 36 different negative stigmatizing experiences from routine prenatal care alone. This isn't going to include other things like time that they spend with their family, their friends, being part of an addiction community, behavioral health care professionals, or if they go to newborn appointments, pediatric appointments, WIC visits, or even family planning. So to me, when I quantified that and started thinking about this from a numerical perspective, holy cow, would you engage in prenatal care or stay there if this was what was going to happen every single time you had a visit? Okay. So now I'd like to take a deeper look at inpatient care. So we're really kind of talking about that outpatient clinical kind of perspective, but this also comes with inpatient care because in our country, most people still have their delivery in a hospital setting. And the hospital environment is both a source of support, but it's also a source of tension for mothers who try to exert autonomy over their infant's care. The environment of being in the hospital can contribute to both internal and external stigma and negatively impact their self-efficacy. Mothers with substance use disorders have told us that they have a heightened awareness during this labor and delivery stay and their postpartum stay, and they often perceive that the providers attend to their infants less if they're in the NICU setting or even in the normal newborn nursery. They feel that the communication isn't there. They're not being informed of the testing that's going on, or they're not being informed of the procedures or their options for pain medications. And they feel that the hospital rules are being enforced more strictly because of their addiction than if it was somebody who did not have a substance use disorder. I did want to include this study. I know that we have some nurses in the group, and coming from a nursing background, it kind of piqued my interest, but I kept it here because I think the perceptions that are described really transcend multiple healthcare professions. I think that anybody can find a connection to some of these perceptions. So this was a study done by Shaw and colleagues in 2016, and they really wanted to look at nurses' perceptions of caring for people who misuse opioids. And they found 4 primary themes. And the first was that nurses told them that they needed more information. They wanted more education for providers, for the nurses themselves, for patients in the healthcare system about opioid use disorder. They wanted to have a better understanding of the effects of opioid use disorder on the dyad. They wanted to know about what resources were available, and nurses who worked in rural areas especially were very concerned about when patients left the hospital, where were they going to get those resources? How could we connect them with those resources upon discharge? And they also felt that we should do a better job of providing this education before they come to the hospital for birth. So this leads back to those preconception visits or those prenatal visits as well. Nurses disclosed that they feel very challenged. They said it's very hard for them to provide optimum care when they're dealing with biases. They felt that sometimes people with opioid use disorder, in particular with this study, could be more demanding of their time, and that management of pain was a primary discussion. Nurses said that they felt that when we created the 5th vital sign of pain, that it placed emphasis on prevention and treatment of pain, and it made it really difficult for them to develop an individualized approach to that pain, and that they expressed a lot of concern about still being able to provide adequate pain relief without worrying that they were contributing to the addiction that the person disclosed. Nurses expressed a lot of concern for both the mom and infant diet. They worried about the ability to provide newborn care. They were concerned about potential for newborn withdrawal once they were discharged. We know that a lot of withdrawal symptoms in the newborn might not present till 24 to 72 hours later. And if we've already discharged somebody at 24 or 48 hours, they were worried that they weren't getting enough education to recognize withdrawal symptoms after that. And they were very worried about the support system of the mom who presented, the dyad. Where was that family support outside of the hospital? And this one I thought was interesting, and I struggled with this one. It said that it was difficult for them to know the truth. And they described it saying that it felt difficult to take a complete history. They weren't sure if the answers were honest, had they disclosed the substances when they came to the hospital. And I had to step back and chuckle, and I thought many pregnant people don't recall dates or information. Many postmenopausal women don't recall that information. And so I think we have to kind of put that in perspective. But the fact that they were recognizing that their bias said, is that honesty an issue, is something that I kind of rated in my head, that is a bias. It's a type of bias they were describing. So this discussion question, I don't know how you're going to feel about this one, but I wondered, as healthcare professionals, do we experience consequences of stigma too? Do we feel stigmatized because we care for childbearing people with substance use disorders? When we see how people with substance use disorders are stigmatized, would that prevent healthcare professionals from reaching out for same type of care should they develop a substance use disorder? We know that addiction occurs among healthcare professionals, similar to the rates that we see in the general population. And when you think about the complexities of disclosure that we find in healthcare, loss of our licensure, loss of employment, restrictions when we return to work, the guilt and the shame, that feels very similar to what people outside of healthcare experience. In a different nurses study, nurses reported hearing when they disclosed a substance use disorder that it was a personal choice, it was a failure of their moral character, and that many of their colleagues did not see their substance use disorder as a disease. And I went, that's exactly what we're talking about. That is exactly that same type of stigma that's there. So my question to you is, do you feel working in this scope of care that you were experiencing any stigma? Do your family, do your friends say, how can you work with people with a substance use disorder? How can you provide them with pain medication? How could you treat them? Anybody had that type of an experience that they're wanting to share? I can get you started. When I was new in my career as a nurse midwife, I worked in private practice. I worked with a population, a clientele that would be described as upper class. They had access to every service that they wanted. And people perceived that to be a fun place for me to work. That must be great. People are, they come in, they can have money to spend on all the tests. They've got family support. And years later in my career, I worked in FQHC, and I worked with a population who often had substance use disorders. They were homeless. They came to us from shelters, and people said, why do you even want to work there? How can you work there? You used to work with this kind of population. And I really had to think about my response and my answer, and why were people looking at me as a nurse midwife providing the same kind of care, but just with two different kinds of population, why nobody had questioned what I did before when I worked with that scope of clientele that happened to be in Denver. I worked in Denver at that time, and then moved to North Dakota where I worked in a community health center. So for me, that's where I started really thinking, gosh, what are people saying about the work I do in this scope? Hey,
As a substance use therapist and working in community mental health, I mean, I do get a lot of questions as far as like, or I get the feedback of like, thank you so much for what you do. I don't know how you do it or why you do it. To kind of in that, like, I would never do that. That'd be the hardest population to work with. I've talked about like, people have asked like, are you going to go into private practice? And well, you can't do private practice with substance use clients is what I've been told. Like, that's what all these other people are saying. That's too risky of a population. You can't do that if you're going to go into private practice. So yeah, there's lots of perceptions and bias for sure.
Yeah. Anybody else have a thought on this one? Again, a lot of these things might just be, what I hope is that if you're not comfortable speaking now, you'll think about them after the webinar, and we can leave some time at the end too. Okay. So I wanted to also include some discussion about the other kinds of stigma that are out there, maybe the things that we don't necessarily think about as contributing to stigma. One would be the mislabeling. We've talked about it a little bit, but the language that we're using, the not person first language, the misinformation that's out there. I often hear babies are born addicted, and that's one of those places where I have to take the time to correct that misinformation and let them know that infants may experience withdrawal symptoms from exposure to that substance use or abuse, but they're not born addicted. And when we look at talking about this from the scope of a chronic disease or medical illness, that addiction itself is a complex interaction between genetics, the brain, the environment, the lived experiences. And what we're seeing is a physiological withdrawal from a substance, not an addiction. I hear often that medications to treat opioid use disorder should not be used in pregnancy or breastfeeding, where our best evidence tells us that there is a safe option for us to treat in the perinatal period. So correcting that misinformation becomes very important. But misinformation is a type of stigma. Then we have our friends in the media, and we do need to include this. So most Americans now will get health information from news media, social media, public information campaigns, but the media holds power. And the power that they have is, one, they get to set that agenda through their media stream. So they get to decide which topics they're going to or allow to have the most attention. And then that kind of trickles over to the public seeing that as something that requires, that's a priority for intervention, or this makes it a bigger deal if they're putting it in the media. And so they often will focus their attention on things that could generate stigma, or it could have the potential to mitigate stigma, but I'd argue that we're causing more than actually mitigating. So we saw with the opioid epidemic, that illicit drug use got more media attention than just cigarette smoking, alcohol use, for example. We saw kind of a shift in what they were highlighting. And did this, I don't know for sure, but did this cause greater stigmatizing attitudes towards people who used illicit drugs, opioid misuse, heroin use, as opposed to somebody who smoked cigarettes? Maybe. They also have the ability to do something called framing. And this is where they can emphasize certain aspects of an issue over others, or influence how the public views that issue. And I thought of a couple different examples. One was the FAS or FASD campaigns that you used to see in some of the media strains. I don't know if anybody can remember. I can picture one in particular of a woman who was very pregnant, and they were talking about fetal alcohol syndrome and all the harm that she was causing to her baby by using alcohol within that pregnancy. But I cannot think of one campaign that talked about the impact of alcohol use on the mother, or the options for treatment for alcohol use disorder when somebody was pregnant. They chose to just talk about the impact on the fetus. The other thing that came to mind were the commercials that I saw, again, when the opioid epidemic really came forward. You would see a lot of commercials of grandparents talking about how they were raising their children. So did that cause stigmatizing conditions towards parents who had substance use disorders, and it shifted that total negative scope to what those parents were doing to those kids? And again, did not talk about treatment, did not talk about the care that was being delivered by other family members, maybe because somebody was in treatment, not that it was an active use disorder. So I think we have to be very conscious about how the media can skew or highlight different aspects of substance use disorders to make our brains lead towards stigmatizing thoughts. How about devaluing the maternal relationship with the child? So saving that infant from a mother who was harming that baby, or restricting participation in initial infant care in the hospital. These are things that cause a disruption in that relationship, and it is stigma. And then also punishment. I don't know if any of you have ever visited the Guttmacher Institute website. It's a central place where you can see information about all of the different states and how they treat people, their laws or their rules around treating people with substance use disorder when they're pregnant. Currently, to date, as of August 31st, we recognize that 25 states and the District of Columbia consider substance use in pregnancy to be child abuse. 5 states consider it grounds for civil commitment. 26 states in the District of Columbia require healthcare professionals to report suspected prenatal drug use, and 8 require them to test for prenatal drug exposure if they suspect that use. So it's just a great site that I'd like to have people visit and just take a look at what they have. But I also tell you that the literature provides no evidence that criminalization functions as a deterrent to substance use. And the American College of Obstetricians and Gynecologists calls for efforts to improve our availability of treatment services to ensure that people who are pregnant with substance use disorders are getting the prenatal care that they deserve instead of being criminalized. Okay, this is just a snippet of some Region 8 information, so you can see the differences between states. This is kind of what it looks like on that site when you go there. So if you look at North Dakota, currently in North Dakota, we're a state that considers substance use in pregnancy to be child abuse. It is grounds for civil commitment. They require providers to report it and to test within our state. And then you can see the difference as opposed to Colorado, where they do consider it to be child abuse, but they also have targeted programs that have been created to help with treatment of pregnant individuals. So these are some of the categories of the information that you'll find at that site. Globally, the United States looks at substance use treatment during pregnancy differently than other places. Two areas that I was able to find some information about included Canada and Australia, but there are no standardized global guidelines that provide recommendations for identifying or managing substance use during pregnancy. There are countries that have national guidelines, but lower middle income countries don't have the same type of guidelines. When we look to Canada, they have no law specific to substance use during pregnancy, and providers don't have a legal obligation to make that report. They really encourage providers to have a flexible approach to caring for people with substance use disorders through a harm reduction philosophy of care. Australia has different requirements from states or territories, but overall, when you look at their literature, they have an overarching emphasis on the importance of establishing a trusting relationship with the client during pregnancy and making sure that they stay engaged in prenatal care and also maintain continuity of care so they're not coming in and out of that care, but they feel welcome to stay in that along with their caregiver during the entire perinatal period. Other access barriers to perinatal substance use treatment, in addition to stigma, include things like in the United States, we often don't have access to gender-specific treatment care. We have limited childcare availability at treatment facilities. And if women don't want to leave their children at home or they don't feel that they have a partner who can care for those children, it might impact their ability to attend those sessions. We sometimes forget in our rural areas, especially, that transportation can be a huge barrier to care. They don't have a way to get there, or they have limited availability for housing, for example. And we know that if they can attend those treatment, if they have a place to live, that is the best predictor for retention and treatment success. It's also interesting, again, especially as I come from a rural state, that we don't have a lot of healthcare providers who have both obstetric backgrounds and substance use treatment expertise. In rural areas, we often don't even have nurse midwives, OBGYNs. We have family practice providers who will see family through the scope. They may not have substance use treatment, or if we have somebody with substance use treatment, they may not be aware of the nuances of prenatal care, for example. We also have to remember that while we talk, and you'll see a slide, pregnancy may be an opportunity to engage somebody in treatment, but the perinatal period is actually a relatively short period of time to be able to provide services or get people into services. And in particular, wait times to access that treatment can be prohibitive. So these are different kinds of barriers that we can also see within this population. Again, one of my favorite quotes: "The way a mother experiencing perinatal substance use disorder is treated and her view of herself as being capable or an incapable mom will impact how her relationship and attachment with her baby develops." Came across that years ago when I first started working in this scope, and all it does is tell me we still have a lot of work to do. So the next few slides are just some opportunities for us to help consider ways in which we can reduce stigma and improve the care that we're delivering. And we started out the webinar with this scope of everybody's language matters. So stigmatizing language is dehumanizing. It contributes to unsatisfactory treatment outcomes. We need to continue to view substance use disorder as a chronic disease and not a moral shortcoming. We really must try to use that non-biased language in healthcare, and we have to be comfortable correcting our colleagues who are using stigmatizing language. And we're going to talk about something called ACTS a little bit down the road here, but we can't just individually make this change. We have to think about where we're working to. So some of the words that I would like us to consider avoiding, and then I try to offer you some words to consider using. So we shouldn't really be talking about somebody who's clean. really what we're saying is they're in recovery. And I think that's a term that's been used for years and years. Oh, they've been clean for this long. Well, really, they're in recovery with their substance use disorder. We shouldn't try to talk about things as being a dirty test. Rather, we're talking about a positive drug test or a urine that tested positive for a particular substance. It's not that it's dirty. One of the newer things that I've seen in the literature is suggesting that relapse doesn't feel comfortable to a lot of people, but instead we could talk about recurrence of use or return to use. Try to avoid things like addict or junkie, again, a person with a substance use disorder. When we talk about drugs in the healthcare scope or in our healthcare system, we might be talking about an antibiotic is a drug. But if we talk about medications to treat opioid use disorder as a drug, the society tends to think of that as something that is continuing the substance use disorder, feeding a substance use disorder. Where if we switch our narrative to say medications to treat opioid use disorder, we're talking about a different kind of substance. Okay, and then we've addressed this, that infants aren't born addicted, but they have a physiological dependence or physiological withdrawal symptoms after delivery. When we look at our education, presenting and discussing the facts, correcting misinformation, increased training for healthcare professionals. That's why I'm always so happy when somebody attends these webinars, because this is what we need to do in a collective space. This is a newer study that came out 2022 that indicated that 20% of surveyed medical students still favor punishing pregnant people with substance use disorders. I'm not a medical student. I haven't been a medical student, but I think we don't have enough content in our curriculum, and we haven't done a solid job of providing that education into that curriculum to talk about substance use disorders. And that education should include things like stigma. How does that connection happen? We also know that most schools of nursing lack substance use education. Some studies have reported maybe 1 to 2 hours total in a bachelor's of nursing program is ever an opportunity to discuss substance use. I feel very strongly about this one, and I think I didn't until I met a person whose name is Lucy. And Lucy is a mother who is in recovery from opioid use disorder. And on the Don't Quit the Quit grant, we, by the way, will provide you with a website URL for our Don't Quit the Quit website. We made it our work in that grant was to create webinars that were free for anybody to listen to that were community focused, meaning these are not webinars you'd go to get continuing education, but they're webinars that are been developed at a community level perspective so that anybody can learn about substance use disorders. And we felt very strongly that we needed to have a webinar with a person who was in recovery, a person with lived experience, so she could share her story about being pregnant with an opioid use disorder and a subsequent pregnancy where she was in treatment for that opioid use disorder. And after hearing her story and the powerful message, I absolutely 100% agree that any education that we provide should include storytelling by people with lived experience. It completely shifts how you look at substance use disorders. This type of action will help us generate more positive attitudes, and it help us to diminish that social intolerance that we have. I've since gone on to work with Lucy in another capacity. She was able to come back to be part of a simulation summit that we provided here at the university for critical access hospital nurses who worked in ERs. And I'm telling you, I could cry right now. We had a nurse attend that summit who listened to Lucy's story and realized that 20 years ago, she was the nurse who had been in the delivery room with Lucy and treated her poorly during her delivery, made the connection during our summit, and the two of them embraced and shared a conversation. And I have goosebumps today. It was incredible to see. And this nurse walked away and just went, my eyes are so opened, and I start today changing the type of care that I'm able to provide. That is the power of including that storytelling. Okay, I also wanted to draw your attention to something called the Maternal Class Standards. CLASS stands for Culturally and Linguistically Appropriate Services. And I've got a link on the next slide to go to this training. This is free. It's online. It takes a couple of hours to go through the content. I hadn't done it in a long time, and this spring went back and did the training again myself. And what it reminds us is that providing services that are respectful and responsive to individual cultural health beliefs and practices, preferred languages, health literacy levels, and communication of needs helps us to meet 6 aims of care. And that includes our ability to provide safe care, effective care, patient-centered care that is timely, efficient, and equitable. It also helps us to increase our self-awareness, meaning that we have to understand that as healthcare professionals, we hold a unique kind of privilege and power. And within that privilege and power, I mean that we have knowledge. We have knowledge that we can share through education. We have expertise that can make a difference in the care we provide. We have the authority that some people will find threatening. So we have to think about how we use our authority to prescribe medications, provide access to treatment, offer educational resources. So we hold this distinct and unique kind of privilege and power that we have to use to the good. If we follow these types of standards, we can also implement better strategies for listening. We can help build better partnerships through shared decision-making, again, including mom in our decisions and our treatment options. And it'll help us to rethink our respect and how we respond to their experiences, clients' values, and their beliefs. And so the link is on here. I know the slides went out. You can go in and out of the training. It takes a couple of hours, completely free, but it was a really good reminder of many things that I had forgotten over the years. Okay, we also need to increase community awareness of substance use and recovery. Remember that broader context of communities in which we live. A reminder that we can't do this alone. It takes a village, if you will, to make these changes. We do have to feel comfortable asking questions, meaning that we have to talk with people about their recovery, talk with people with lived experience, and talk with our colleagues. Similar to the discussion points that we included today. Those are good conversations to have in our work settings to see where people are at and share our experiences. This is something that I had found, it's a 2019 reference called Mothering and Opioids, Addressing Stigma and Acting Collaboratively. And these were comments and quotes that mothers provided of things that they wanted healthcare professionals to know. Mothers want to succeed. Don't assume we're not trying or that we chose the challenges that we face. They ask us to listen and be curious about what might work for each of us. They asked us not to judge, instead care, and they asked us to show empathy and not pity. That is power right there. So I said this before, but pregnancy is an opportunity it is a window of opportunity where we help engage people in treatment and recovery. Remember that window though is small. It's important for us to be open and transparent about our testing and our reporting requirements. This is an area where I often drew on my social work colleagues to say, help me walk through this, help me understand the current laws to make sure I'm doing what I need to do. I'd like people to consider that universal screening can be done through self-report, meaning we don't always have to jump to that blood test, that urine test, but self-report tells us a lot of information. We need to consider peer services as part of these opportunities. We also should look to the opportunity to deliver group prenatal care. Mothers find strength within that type of education community. And peer support can be a counterbalance to the discrimination, to the rejection, isolation, and stigma that that people with substance use disorders are experiencing. And it may help them sustain longer and more regular treatment options. So we're seeing peer support take off in North Dakota. I hope you're seeing that in our states as well. I look to Debbie because the newest nuance of peer support is actually having people train as doulas as well. And that is fascinating to me. Arizona has made some progress there. Illinois has made some progress there, but I hope we see more happen in that scope. When we think about that inpatient type of scenario, we need to work to create those caring environments and try to involve moms in all aspects of infant care. That is empowering for moms to be part of that care. They need to build that confidence in their ability to mother. We should review our perinatal strategies to prevent unnecessary use of pharmacological pain management, but how are we providing adequate pain control? Our doulas welcome in our systems. Our families welcome to be part of that birth experience. Try to work to keep mothers and infants together. Think about breastfeeding and rooming in as a kind of first line treatment for neonatal abstinence syndrome during that birth hospitalization, and really try to emphasize those community resources. Remember, nurses especially said, we don't know where to refer moms to upon discharge. We want to know where these resources are, and do we have a good referral system that is set up. We have to support our providers. I think it is fair for us to recognize that when we care for families impacted by substance use disorders, we may experience ethical distress, we may feel some moral distress, and we certainly know that compassion fatigue becomes part of our care. So it's helpful for us to be aware of our biases, continue to grow our knowledge. We have to learn about associations with substance use disorders, things like intimate partner violence, the impact on family dynamics, the impact on social support systems. We have to be aware of our treatment options. And I would just ask that we all try to be kind to each other and patient, because this is not a scope of practice from a healthcare perspective that everybody goes into. And there's a learning curve that goes into providing care here. And then finally, I just wanted to let you know about the ACTS script. So ACTS is a guide that helps us to respond respectfully and constructively in situations with our coworkers. So this might be a situation where you're working with somebody and they have something negative to say about a mom who comes in for care with a known substance use disorder. And ACTS just simply means that we acknowledge the situation or create an opportunity to start having a dialogue with one of our colleagues. We create a circumstance for reflection. So maybe we ask a question out loud, or we think out loud about the situation that presented. It gives us a space to teach, share an article, share a webinar. Have you heard about this? And give some knowledge that you've learned. And it also asks that we support the change that happens. So we encourage our colleagues to try new approaches with our clients. We give them new words or language to try, but then we celebrate those successes and we acknowledge the change that has happened. So this on the ATTC website, the Mountain Plains ATTC website, we included some different things about they're called curriculum infusion packages. But as part of that work to get this content into academic centers, we included some case scenarios with this ACTS script, but how you can work through a particular scenario and apply the ACTS script to address the situation at hand. So those are free resources on the M Mountain Plains ATT site that you have access to try to practice this type of dialogue as well. So in conclusion, the stigma is real, it's out there, but so is our opportunity to impart change and to support people who are pregnant and parenting with substance use disorders. I do ask that, I know Jen has a link to a survey. We ask everybody to complete that afterwards if you would. And the last thing I included for you was a short YouTube video. I don't know if any of you have read Dr. Turplin's work. Is well cited in the literature, but I came across this video and it really talked historically about substance use disorders with women in particular, and he had some really interesting things to share. And I went back to double check before this webinar to make sure the link is still active, and it is, and I listened to it again, and I always learn something different when I listen to it. It's an easy listen, but I love the historical perspective of how women came to use substances, and which often started with morphine as the drug of choice way back in the day. But it's just an interesting thing that I like to share with audiences. So with that, I will stop sharing, and I think that gives us a whole solid 10 minutes to see if you have any questions or things that you want to talk over or address before our time is up.
while you all are thinking of your questions for Merity, I'm going to send a follow-up email after this, and that will include a lot of the resources that Merity shared, and the Don't Quit the Quit website, and the Mountain Plains Addiction Technology Transfer Center, all of those things as well as the evaluations, which thank you. Haley put those in the chat for us, but they'll also be in the email that's coming to you all shortly. So hopefully that was enough chit chat to let you all think of your questions before we let Merity go for today.
I will let you know that if you do go to the Don't Quit the Quit website, there are 18 recorded webinars on there. All of them are about 30 minutes, and they are completely appropriate for sharing with clients, sharing with families. We created many of them for WIC colleagues and people in community. So again, they're not the type of resource that we usually find. I know many of us will look for continuing education. That's not what they are. These are we often refer to them as mom talk. So we took the evidence and we created a way to talk about it that was easily understandable, and they're completely free, and we'd love for you to use them. And most of them run around 30 minutes. There's one in particular that addresses alcohol use disorder, and we even include a recipe for non-alcoholic slush because we delivered it in July and we thought it would be great. So they're very much user-friendly videos and webinars.
I love that.
Can I just say thank you? This has been the most amazing webinar ever that I've ever been to. So much great information. Oh my, I have no words. Thank you.
Oh, thank you very much, Debbie. I greatly appreciate that.
Excellent. And we would greatly appreciate it if you put those fantastic words into the evaluation so we can share that with everyone. Fantastic. Thank you so much. Well, with that, I wanted to say thank you, Merity, for sharing this. Of course, thank you to the HRSA Intergovernmental and External Affairs Office, Region 8, for making all of this happen. We have our next session is going to be next month on November 16th, looking at perinatal mental health awareness and screening and treatment. So we do hope you'll join us. The registration link is still open, so you can share that with your colleagues if you'd love for them to join us as well. And the recording will be available. And Eve, I see your hand up, so I'm going to.
I was just going to add out there, because some of the stuff that came up in the slides was, the short period of time that they're pregnant. In Colorado, when we get a referral for somebody that is pregnant, that it's identified, I think we have like 2 or 3 days to offer. Like, they have to get an appointment offered within 2 to 3 days. It's very, very hard for us to do that, but like legally we have to, whether they accept that one particular time that we were able to get them into, that's a different story. But so definitely, if you're in Colorado and hesitant about referring, make sure that you do, because we are getting them in, and that's part of why we have been seeing a lot more. So even though treatment is limited, it is a priority population that we work with.
Great. Good to know. Excellent. Any other comments, questions?
I don't necessarily have a question, but I also wanted to thank you for today's presentation. And I really appreciate all the resources that you provided us, and can't wait to go look at them. My background before this role was in child maltreatment prevention, and really that translates to just supporting families and women and fathers. So this all spoke to me. I did want to mention, just like as a comment too, that I was at a recent work group for our Department of Health, and when it comes to maternal mortality in South Dakota, it was about 46% of those cases in the year that they were looking at. I can't remember if it was like 2019 or so that they had reviewed, but 46% they were able to identify discrimination of some sort contributing to that mortality. And so I just think this is a really important topic, not just, discrimination may happen, but like to actually be able to tie it to mortality just really shows how impactful that really can be. So thank you.
Thank you for sharing that, Tracy. Sometimes when I put morbidity, mortality, death, on that consequence slide, and people are like, what? That is exactly what we're saying there. And it's all of the things that come along with that stigma. Thank you for pointing that out.
Excellent. Anybody else? We have a couple minutes. I don't want to cut anyone off. Excellent. All right. Well, thank you all so much. Email will go out very shortly. Thank you all for taking the time to meet with us. And I would love to see you again next month. So thank you all.
Thanks, everybody. Have a good day.